today. I'm really excited to have this naloxone training. And I know a lot of people in the L&D world are new to naloxone, but we are really excited to host this training because, the impetus, I guess, for this learning collaborative is the AIM opioid use disorder patient safety bundle. And that patient safety bundle does include, sending patients home with naloxone if they are identified as having SUD or if someone in their close circle or close family has SUD. And so as you build out your SBIRT protocols, we encourage that giving patients a prescription for naloxone or dispensing naloxone, which we can talk about at the end of this call, should be a part of what you do when you have a patient that screens positive, or if you have a patient who, for whatever reason, you're able to find out that one of their close friends or family members or partners uses substances, I should say. And Marley will explain why it is important for substances in general and not just opioids, because of the prevalence of fentanyl in everything these days. So really important, and I think now is a great time to talk about it because as so many of you are doing amazing on screening, now that you're screening patients and you're able to identify patients with substance use disorders because you're screening them, now is a great time to start thinking about how do we build into our protocols and our workflows, making sure that this patient goes home with naloxone and is given naloxone education. And Marley will get into this too, but both the patient themselves and anyone else that's in the room with them, because a patient cannot reverse their own overdose. So it's important that anyone around the patient also knows how to use naloxone to reverse overdoses. So with that being said, I'd love to introduce our presenter, Marley Yost Wolf, and we can get started.
Hi, everyone. Thank you so much for having me. I'm super excited to get to do this for you all and very excited about all the work you are doing. I have my PowerPoint. Katie, do you know if I'll be able to share my screen?
Yeah, you should be able to share your screen if you look at the bottom bar.
Sweet. Let me just see here. Alrighty, can you all see my screen?
Yes, we can.
Okay, perfect. So today we're doing a naloxone and just in general overdose prevention training. My name's Marley. I work for the Colorado Health Network, and I work really closely with Caroline Bunn, who works at Summit Stone, who I know was super helpful in getting this training set up. Together, we work for the Northern Colorado Harm Reduction Alliance, which is a work group of folks from a bunch of different organizations, all just working together to increase access to naloxone and education around naloxone in our communities. This training will be about 45 minutes overall. We'll have time for questions throughout and at the end too. And I would just really encourage all of you to ask your questions. That's how we learn best, as I'm sure you know. And there's definitely no silly question, especially when it comes to this topic, because we've all learned different things throughout our lives. So please ask your questions. And then I also want to note there's a couple other organizations just on this slide here that have helped develop this training. And a lot of the content in this training is adapted from the National Harm Reduction Coalition, which is a resource I'll definitely point you all towards at the end. They are just amazing, have so much information out there, specifically on pregnancy and substance use too. I will do my best to look at the chat, but if I miss things, just unmute and say something.
I can help you with that too. I'll let you know when there's something in the chat because it's so hard when you're sharing your screen.
Yes, yeah. Thank you, Katie. Awesome. I have a quick question or two for you all, just to get our brains going. So on a scale of 1 to 5, 1 being you don't know how, 5 being I feel super confident. I'm wondering how confident you all feel in your ability to reverse an opioid overdose with naloxone if you needed to. If you all could just drop your number in the chat, that would be amazing, and I'll kind of gauge where we're at. Cool. Awesome. I'm seeing we have quite the range of experience in this group, which is wonderful. That's super normal, and folks who know a lot, feel free to jump in too. I'm sure that there's some things that you could teach us all too. The next question I have for you all is, again, on our scale of 1 to 5, how confident do you feel in your ability to talk with patients about opioid overdose prevention? Sweet. I'm seeing a range again, which is normal, and we'll definitely talk about both today. So hopefully all of you at the end of this training will feel a little bit closer to that 5. Awesome. The last question I had was for anyone on this training who your unit is already distributing naloxone to folks just directly in your unit, in your position. The naloxone that you're distributing, is it the nasal spray or the injectable? I'm just curious. It's okay if you're not sure, if your unit hasn't started doing that yet too.
I do know that one of our 2 teams who have begun dispensing naloxone, one of them is going to join us towards the end of this call, but they, I believe, are distributing the Narcan nasal spray and not the injectable.
Okay, awesome. We'll talk about this more when we go through as well, but naloxone comes in a couple different shapes and forms. We'll spend the most time on the nasal spray because that's typically what's the most accessible to folks when they're getting it from a pharmacy too. So we'll spend the majority of our time there. All righty, thank you all for participating in that. Let's go ahead and get started. So kind of to set the tone here, I have a couple of statistics. They're Colorado specific, so apologies to all you Montana folks. But just some statistics about where we're at in the overdose epidemic in Colorado today. And in the US in general too. So we know that in 2020, there were over 93,000 drug overdose deaths, which was the largest single year increase on record, going from 2019 to 2020. Drug overdoses are the leading cause of death among people under 50. And I think that it has been that way for quite some time now, a couple years. In Colorado specifically, there is a fatal overdose every 5 hours and 56 minutes. And as we're focusing on today, opioid overdoses, right? They account for 70.6% of overdose deaths nationwide. So the vast majority of drug overdose deaths are coming from opioid overdoses. Lastly, fatal overdoses in Colorado cost Colorado a lot of money. The most recent data we have on that is from 2017. But yeah, it's costing our healthcare systems a lot of money, and we're losing some amazing people. So yeah, this slide is definitely a little bit heavy, So I just want to acknowledge that, and also acknowledge now as well that this topic can be heavy for folks too. So please feel free at any time throughout this training to take a moment, excuse yourself, turn off your camera, disengage, whatever you need to do to take care of yourself too. Alrighty. Also, during this training today, I'm going to use intentionally some language that you all may or may not have heard of before. On our left here on this slide, we have some examples of stigmatizing language. Some of this language you all may have heard before. Some of it is pretty ingrained into our society, which is okay. But during this training today, I'm going to try to use some less stigmatizing language. A big piece of that is person first language. So instead of saying someone is a drug user, they're a person who uses drugs, right? We're putting them and their whole person before their substance use. Additionally, I try really hard to refer to naloxone or Narcan as a life-saving medicine instead of a drug, just because, especially when we're talking about substance use, even just the term drug sometimes can have a negative connotation. And then also, again, person in recovery rather than former addict or reformed addict. And when we're talking about addiction, we can also talk and use the language person with a substance use disorder or someone experiencing problematic or chaotic use. So I would encourage all of you, as you're thinking about this topic during the training today, and as you're asking questions and such, to kind of try on using some of the less stigmatizing language with me and see how it feels for you. A lot of times, less stigmatizing language can be an important way that we let our patients and our clients, just other people in our lives, know that we really care about them and that they deserve all of the good things in the world that we all deserve too. Because stigma is really powerful when it comes to substance use, and we can all be a part of combating that. Alrighty, so I'm going to go ahead and dive into recognizing an opioid overdose. This might be review for some folks. I know a lot of you are healthcare professionals, but we'll go through it. It's important to review this information as well. So, signs of an opioid overdose. We have 6 of the main signs on this slide here. Folks experiencing an opioid overdose, the biggest things are they may not be responsive and they may not be breathing normally. Because of that, there might be a couple other signs that we can look for here. So blue lips or nails is one especially that is good to look for. And that's happening, right, because our person is not getting as much oxygen as they need. As well as, can't be woken up. They may be dizzy or confused, maybe making choking, gurgling, or snoring sounds. Their breathing is disrupted, or they seem to be drowsy or having difficulty staying awake. A couple other things to note that aren't listed on this slide. For folks with darker skin, their skin may turn a grayish or an ashen color, whereas folks with lighter skin, their skin might have a bluish or a purplish hue. We've also heard a lot about folks' jaws being locked as a reaction to fentanyl, which fentanyl specifically we'll talk more about later. And then of course as well, depending on where this person is at, where the overdose is at, this person may have a pulse, they may not have a pulse, or their pulse might be slow or erratic. So all things to look for. So if we're noticing this, what can we do about it? The first thing we'll want to do is assess the situation. So obviously, when we're responding to anything, our safety is our top priority. So before we do anything else, we want to make sure that we're safe. Otherwise, we're not going to be able to help someone else. Next, check for responsiveness. So what we recommend for checking for responsiveness is a sternum rub. Can you all see me as well as the slides? Yes. Okay, cool. So what you're going to want to do to check for responsiveness for sternum rub is take knuckles to Folk's sternum and go ahead and press. The reason we recommend this is it's not really going to cause any additional harm to someone, but it is pretty painful. So if someone can respond, they will typically respond. If you're not able to reach their sternum kind of quickly, you could also do the same thing with their upper lip like this. The next thing, if someone is not responding, is to call 911 as soon as possible, right? We want to engage further medical care. This might not apply to all of you necessarily, but especially when you're training your patients on using naloxone, we want to emphasize that calling 911 is best practice, a great thing to do. And we'll talk more about some of the complications or the questions people may have about that later too. And then, especially if our person is not breathing normally, we can perform rescue breaths or CPR. CPR only, of course, if they are not breathing properly and they don't have a pulse, right? Which I'm sure you all know. And then if we have to leave them for a certain amount of time for whatever reason, we can put them in the recovery position. So that is kind of demonstrated on the right on our slide here. Really, we want to make sure that they're on their side so that if they do vomit, they're not going to choke on that. And also, especially when we're working with folks who are pregnant, if we're able to maneuver people onto their left side, this may help increase blood flow to the placenta too. All right. Next, we're going to go into delivering naloxone. But before I go there, does anyone have any questions for me?
This is Amber. I'm curious why it would be painful to rub the sternum when you mentioned that it would be painful.
Painful maybe wasn't the best word. It'll just cause discomfort. You can press pretty hard without causing additional trauma or harm to this person. But that's just best practice for getting someone to respond if when we, tap their shoulder and say their name, they're not responding to us.
Okay, thank you.
Good question.
This is Elena. I am a first responder and I work on an ambulance. If you try it on yourself, Amber, you're like rubbing your knuckles against like the bones and it creates it's like this motion and it will hurt a lot. So yeah.
That makes sense. I was kind of wondering too, if there would just be any reason for heightened sense of pain or sensitivity during that time, but that makes sense. Even in any circumstance, it would be uncomfortable.
Yeah.
Yep, definitely. Thank you.
Any other questions? Alrighty. I will keep us moving. So what is naloxone, commonly known as Narcan, the brand name for the nasal spray? Naloxone, it's a medication that reverses the effects of an opioid overdose. When someone is experiencing an opioid overdose, there's too many opiates stuck to the opiate receptors in their brain, which is causing their breathing to slow and eventually stop. What naloxone does is it comes in and it swiftly removes the opiates from the opioid receptors in their brain, which allows breathing to restore and reverses the overdose. It's important to note that naloxone only reverses opioid overdoses. So if someone is experiencing an alcohol or a stimulant overdose, naloxone will not help them. And then there's 4 different types of naloxone. We're going to focus the most on Narcan, the nasal naloxone, but there's also injectable naloxone. That's an intramuscular injection. There's a couple of different types of that injectable naloxone. There's some pre-filled vials, some auto injectors, et cetera, et cetera. Nasal spray is really the most common and the most accessible, so we'll spend our time there. I also should mention that I am not a doctor or a nurse or really a medical provider at all. So this is what I know. You all are definitely the experts too. So just know that throughout this training as well. My expertise is really just naloxone. Alrighty, so here's images of a couple of our different types of naloxone. Again, we're going to focus on the nasal spray, but just know that there's other ones that exist here too that your patients may have access to. Nasal Narcan. So in a box of nasal Narcan, there are 2 doses, holding one up to the camera here for you all, that look like this. It's important to know that there's only 1 dose per applicator, and there's no need to like prime your dose or anything like that. So as soon as you go ahead and spray, you will be administering the whole dose. Kind of as you can see here on this slide, the nasal spray is pretty easy to use, to be honest. Just like any nasal spray, like Flonase, anything, you're going to go ahead and place the applicator in the patient's nose. This image is good, but it's not the best because the applicator really isn't all the way in our patient's nose. It does need to be in the nasal cavity, right? And then go ahead and push the red piece on the applicator to administer the dose. A common question that I hear from folks when I'm giving naloxone trainings is, if my person who overdosed is not breathing, how are they able to get this medication through the nasal spray? And the mucous membrane, the medication actually is absorbed into the mucous membrane. So even if the person isn't breathing, they're still going to get this medication. Some other just fun things about nasal Narcan: it's easy to carry around with you, to have in your, just like your purse or in your pocket or your car. It's just as effective as the intramuscular injections, and it's the kind that is most widely available at pharmacies. A couple other things that are important to know about naloxone. It can take multiple doses of naloxone to reverse an opioid overdose, depending on the circumstances of the overdose. So, especially with fentanyl involved, which we will talk about later, we've heard that sometimes it takes upwards of 6 doses to effectively reverse an opioid overdose. It's totally okay to use more than 1 dose on someone. What's recommended is you administer a dose and you wait 2 minutes and look for any signs or changes in your person. If you're not seeing any changes, you can go ahead and administer that 2nd dose. For the nasal spray, just go ahead and do it on the other side and the other nostril. Again, naloxone or Narcan only reverses an opioid overdose. So, especially when we're talking about polysubstance use, if our person used opioids in addition to alcohol or benzodiazepines, for example, naloxone may restore breathing but not full consciousness, and so on, which is why it's so important to call 911 and get some further medical care. Lastly, a big question out there is if we could possibly hurt someone with naloxone. The wonderful news is naloxone is an amazing medication. It's pretty impossible to harm an individual with naloxone. The only caveat to that would be some people might be allergic to naloxone, just like some people are allergic to other medications. But there's really no way for you to know that, right? Unless you have that information in front of you at the moment. When in doubt, whenever someone is unresponsive and not breathing properly, we can use naloxone. If they're not experiencing an opioid overdose, naloxone just won't work on them, but it will have no negative side effects. And because naloxone really swiftly knocks the opiates off of the receptors, a person who just experienced an overdose, when they receive naloxone, might experience some pretty intense withdrawal symptoms. So they may be agitated, ill, scared, and that's completely okay. There are some things that we can do to be as helpful as possible in this terrible situation. So here's some guidelines from the National Harm Reduction Coalition. Some nice little scripts for folks. And just a reminder to give folks space and speak in simple and kind sentences in that moment. It's also important to mention, kind of at the end of this, towards the end of this slide, trying to stay with the person for 90 minutes. The reason for that is because naloxone only works for a certain amount of time, again, depending on the circumstances of the overdose. So it typically works anywhere from 30 to 90 minutes after administration. Naloxone will be filling the receptor in the brain and keeping opiates from attaching back to the receptors. However, after those 30 to 90 minutes, someone could potentially go back into an overdose if the opiate effects last longer than the naloxone, which is why it's really important to call 911 and get them some further medical care. Or if that's not possible or safe for whatever reason, making sure that our patients know that it's important that they stay with this person or have an overdose prevention plan in place that they can pull from to make sure that this person doesn't go back into an overdose. Alrighty, what questions do you all have about administering naloxone?
Marley, I think you're going to get to this, but I'll just say it. I know we talked about like safety during pregnancy and what it means if someone is pregnant and needs to take naloxone. So I think you're going to get to that, but if you're not, can we talk about that?
Yes, I will get to it. I can just skip ahead real quick because it's not too far in front of us. Here we go. Yes. Right now, the recommendation is that we use naloxone with a pregnant person in the exact same way we would use naloxone for anyone else. So there is a chance that the overdose and the overdose reversal could cause stress to the pregnancy, could increase risk of complications. However, the risks posed by the pregnant person not having oxygen or potentially dying from this overdose outweigh the other possible risks that might come from using naloxone on someone who is pregnant. So yeah, know that this is coming directly from the National Harm Reduction Coalition's Pregnancy and Substance Use Toolkit, which I will make available to you all as well. Another thing to note here is, again, why it's best practice to call 911, right? Because some of these complications might come up from someone who overdosed and then that overdose was reversed. So really getting them that further medical care, making sure that they're engaged and talking to providers about this is going to just be the best for them and for their family too. What other questions do you all have? Alrighty, I'm gonna move us into calling 911 quick because we've been talking about that a lot. There is a myth that's pretty prevalent out there that folks can get in trouble for using drugs if they call 911 when responding to an overdose. And thankfully, that is a myth here in Colorado and in Montana as well. We have Good Samaritan laws in both states that protect the person who's calling 911 and the person who overdosed from any drug or drug paraphernalia charges. That includes alcohol and marijuana for underage users. It's important to note that the Good Samaritan law does not protect you from all potential charges, only drug and drug possession charges. As well as if there's a warrant out for either person, that warrant could be pursued by law enforcement. So I wanted to give you all this information, especially for when you are training your patients on using naloxone. It's really important that of course, that you emphasize that it's best practice to call 911 when someone has overdosed to get that person further medical care. However, recognizing that that might not always be safe for everyone in every situation, and that folks, as much knowledge as we can give them, then they can make the best decision for themselves in their situation. So definitely encourage you all to bring up the Good Samaritan law when you're talking to patients about overdose prevention. I also have some tips for you all to mention to your patients when they're calling 911. One big one is when we're calling 911, it's recommended that we say, instead of saying that someone has overdosed or is overdosing, we say that someone is unresponsive and not breathing or having trouble breathing. Describing the symptoms rather than saying exactly what happened to this person is helpful. It's also helpful, especially when we don't know exactly what's going on with this person too, which really might be the case for some people, especially in polysubstance use, or even if we just as people in the world come across someone who's unresponsive and not breathing, right? We don't necessarily know that it's an overdose, but we can definitely describe the symptoms when we're calling 911. Once help has arrived, reminding folks that what they really need to focus on sharing with EMS is what the person may have consumed, if they know, and whether or not they had the opportunity to administer naloxone. If so, how many doses, and so on. And that is really the core of the information that emergency responders need to best help this person who has overdosed.
Marley, we do have a question in the chat. Are auto injectors really uncommon to use?
Great question. I actually have one right next to me right now. So for folks who don't know, an auto injector, hopefully, Erica, we're thinking of the same thing, but an auto injector, the one I have in front of me, is injectable naloxone that talks to you. So once you open it, it gives you kind of the steps of what to do. It kind of helps you, guides you through that process so that you don't have to memorize that. And then it's also just like kind of a more accessible syringe for some people too. Because the needle's in here, it's not like you have to draw the medication up into the syringe. So that's what an auto injector is. I would say they're pretty not common because they're so expensive. So for someone who uses substances, has a substance use disorder, getting prescribed this, even if they were prescribed this or able to get this from a pharmacy with insurance, it would be pretty pricey compared to the nasal spray. I have yet to meet someone other than organizations or hospitals that have auto injectors. So definitely important for you all to know that this exists in case this is what your hospital has or the place that you work. But it's not something that's terribly common for just folks, for our patients to have access to. Awesome. Any other questions? Y'all are asking great questions. Alrighty, I'm going to keep us moving. Another myth out there that is kind of a common question, I would say, from community members who might be kind of separated from learning or reading about overdose and the overdose epidemic, as well as a question that I would say people in recovery sometimes have too, is if the naloxone enables substance use. The answer is the only thing naloxone enables is breathing. Really, it can only be helpful in saving a life. If you all get asked this, I would just encourage you to remind folks that if someone is dead or has passed away, that's it, right? There's no chance of recovery or of them making any steps towards goals in their lives. We really want to keep people alive so that they continue to make the best decisions for themselves. There's also no evidence that having naloxone available or accessible to folks in a community increases substance use or increases any sort of risky substance use. I like to tell people naloxone is like having a fire extinguisher. Of course, if we have a fire extinguisher, that doesn't encourage fires to start. It just gives us a tool to use if there is a fire so that we can keep everyone safe. Another myth out there that we have been hinting at is that only opioid users need naloxone. The truth is that anyone using any sort of illicit substance could experience an opioid overdose and therefore needs naloxone, and so does their close friends and family, their community. The reason for that is largely fentanyl. So for folks who may not know, fentanyl is an opiate that's 50 to 100 times more potent than heroin. And it's appearing in pretty much all across the illicit drug supply. So it's in meth, cocaine, Molly, street, Oxycontin. It's in heroin for sure, across Colorado and the United States as well. And because it is so powerful at such a small dose, folks using cocaine are dying from an opioid overdose because there's just a tiny bit of fentanyl that from cross-contamination made it into their supply. What I have on the left, this public servants announcement is from Dance Safe, an amazing harm reduction organization, about some Colorado. Alrighty, I'm going to go ahead and move us into some tips for when we're talking about overdose with patients and with people in our lives. So we've been talking a lot about naloxone. As you all know, naloxone is a form of harm reduction, and harm reduction, more broadly defined, is a set of practical strategies and ideas aimed at reducing negative consequences associated with fill in the blank. So I have a couple of other examples of harm reduction here on this slide. Condoms, seatbelts. Do you all have any other examples of harm reduction you could think of? Masks are a big one, right? It's risky to see folks because of COVID. However, if we're going to choose to engage in that risky activity of seeing folks because of COVID, we can wear masks, which will reduce the risk of transmitting COVID to one another, right? A really great example.
In the chat, we have some great ones. Helmets, car seats for children.
Awesome. So when we are thinking in the framework of harm reduction, and when we're talking with our clients about substance use, I have a couple of tools, some of them that we've already touched on, that you all can kind of keep in your toolbox to pull out when you're having these conversations. The first one, using person-first language. Again, recognizing the person before their substance use. That really shows folks how we see and value them. The language we choose is very important. In addition, unconditional positive regard. So the idea that everyone is inherently good, and recognizing that everyone, each and every person is doing their best at all times to take care of themselves and their family. Even if what they're doing to help take care of themselves might not seem like it's helping them take care of themselves to us, they are trying their best to take care of themselves. And so making sure we're treating people with that understanding in the back of our minds at all times. I also have reflective listening and affirmations on here. These are pieces of motivational interviewing. I'm not sure if you all have heard of that, but a super cool set of tools for helping us talk with people about hard subjects. So reflective listening, making sure that we're really listening to what our patients are saying and what they need, and that we're kind of responding back by letting them know what we're hearing from them. That really holds space for people, and it also holds space for their contradictions too. And then affirmations are my personal favorite part of motivational interviewing and working with people. Because, as we know, many people who use substances experience a lot of stigma in their daily lives. And oftentimes people internalize that stigma and they believe that they deserve the worst because of their use, which is not true. And affirmations are a great tool we can use to help people recognize that they're doing their best and they deserve all the good things in the world that we all deserve. They can also be very useful in acknowledging that people who use substances may already know a lot about naloxone and overdose prevention. They may have saved someone's life before, someone may have saved their life. When we're giving them the naloxone training, they may know most of that information already. So something that I do when I'm giving folks naloxone trainings is I always start by asking people what they already know about naloxone or about opioid overdoses. And then from there, we can affirm people in the knowledge that they already have, while offering, of course, any additional insight and gently correcting any myths they might have too. Lastly, just recognizing that relapse is a super normal part of recovery. So even when we're working with folks who may be engaged in medication-assisted treatment, or maybe in recovery in some shape or form, just knowing that the relapse rates are really, really high, especially with opioid use disorder. And so it's important to recognize that they may need naloxone, and also just making sure people know that we know that relapse is often a part of recovery journeys. And they haven't failed if this happens to them. They're still doing their best, and it's just something that happens sometimes. Alrighty, So what I would encourage you all to do when you're having these conversations, of course, it's amazing to talk about medication-assisted treatment, amazing to talk about recovery and about abstinence, but also recognizing that not everyone that we meet and work with may be in a place where they want to be engaged in treatment, or may not always want to be engaged in treatment or in recovery throughout their lives. And there are other options and ways for them to stay safe and reduce the harm or the risk of opioid overdoses, even when they are using substances. So a couple tips, harm reduction tips for folks. It's safer to try to not combine substances because specifically alcohol and benzodiazepines can increase the risk of an opioid overdose. We also know that if folks are using stimulants and using opiates, using one substance at a time is a good idea. Or if they want to use, really want to use both, using heroin or the opiates first will help reduce overdose risk. Again, reminding folks that prescription pills don't always mean that you are safer, especially if you're getting this pill from your friend. There might be fentanyl in there, and reminding folks that especially for folks who are in recovery or have just had a period of abstinence or a period where they've been really engaged in medication-assisted treatment, their tolerance might be lower. So if they relapse or return to use, it's a good idea to start low and go slow. As well, folks can be encouraged to test their supply with fentanyl test strips from their local syringe exchange or local harm reduction organization. And then there's, of course, steps that they can take if their substance does come back as positive for fentanyl to reduce the risk of overdose. They could do a tester shot, they could smoke or snort instead of injecting. Plenty of ideas around that in terms of if we need to use this, how we can stay safe in using it. And then also a huge piece of overdose prevention is not using alone or using in isolation. So this is kind of what Katie was speaking to earlier, right? Someone who's experiencing an opioid overdose is typically not able to use naloxone on themselves. Even if our people are trained on using naloxone, if they don't have a friend there with them to use it on them, they're not going to be safe. So it's really important that folks talk about their use with their friends and their family, that they have that support system, people there to use naloxone on them if they need it. There's also an amazing hotline out there called Never Use Alone that will call EMS for you if you experience an overdose and help kind of monitor your use even when they're not there with you in person. Alrighty, I know we're going a little bit over. Are we okay to keep going?
Yeah, we're totally fine to keep going.
I just have a quick question and comment. The last slide of like how to use safely is something that's very unfamiliar to me as a physician, and I am just wondering if you can give some practical advice about. It just seems as though if you recognize that somebody's not ready for treatment, this seems like the next obvious step. Say, okay, if you're not ready for treatment, I want you to be safe. Mm-hmm. But do you have other ways in which you can bring that about? Because it almost could be interpreted as advocating for use. And I know that's not what it is, but it could be interpreted that way.
Yeah, absolutely. Great question. I would say lean pretty heavily in your conversations then. In that disclaimer of, I'm a physician. I'm letting you know that that obviously, like the safest way to avoid overdoses is to not use or to be engaged in treatment. But if you are going to use, I still want you to be safe. So here are some things that you could do to stay safe if you do use. Especially with what we know about relapse being so common in recovery journeys for folks, I think it's really important that we think about overdose safety planning as obviously not just saying that use is okay and everyone should use, but really focusing on reducing the harms that we can when we're being really, really practical about it. I would say from what I know and from the folks that I work with, people generally don't want to use, but they're still using, and that can be really complicated. And it means a lot to folks to have options to stay safe if they do use, and to know that they have a safe person in the healthcare world to talk to about this, because ultimately, the more that they keep it to themselves, the less safe they are in that too. I'm not sure if that helped answer your question, Erica. Did my best.
No, that was great. You're trying to model or think how you could say this in the most, compassionate and empathetic way, but also to not sound as though you're sort of encouraging use. And that was appreciated. Thank you.
Yeah, of course. Yeah, I think language around the safest choice, another safe choice, kind of that language would be helpful, and definitely also like say what you're comfortable with too. I do have a resource for you all too that we'll get to at the end, that kind of maps out like an overdose safety plan that you could use when you're talking with patients, that has a couple of different options on there too, and kind of goes through like 1, the safest option, 2, another safe option if the safest option isn't available to you or you're not able to do the safest option. So you're not alone in it too with just your words necessarily. Any other questions from folks? Alrighty. This slide is just, again, the more that we are talking about substance use, the more we're destigmatizing substance use, and we're letting folks know that they're not alone in their substance use and they're not being judged for their substance use. That's reducing some of the negative consequences that are associated with substance use that people might really internalize, which is increasing our trust and our engagement with our patients or our clients, and ultimately is improving individual and community health. All right, I'm going to go ahead and jump into where folks can obtain naloxone and harm reduction resources. Since I know a lot of you all don't have the ability to just hand someone naloxone necessarily, you can definitely hand them a handout that can point them in the right direction to get it to. So in Colorado, and I believe in Montana as well, folks do not necessarily need a prescription from a doctor to get naloxone. There's a standing order on naloxone in Colorado since 2015. Anyone can legally obtain naloxone from a pharmacy, and most insurance plans cover naloxone as well with a copay. And then there's a couple different places folks can get naloxone. Pharmacies are a safe bet. I have a link here to a website, but honestly, it's not the most updated website. I would say that pretty much every pharmacy likely carries naloxone at this point. And so folks can just go to their local pharmacy and ask for naloxone and receive it. For folks who might not be comfortable doing that, there's also a mailing program in Larimer and Weld counties up here in northern Colorado. And then there's a national naloxone mailing program as well. Additionally, especially for folks who might not want it sent, naloxone sent to their address for whatever reason, and aren't able to go to a pharmacy for whatever reason, there's also harm reduction organizations in the state of Colorado and Montana. Montana, I think there's 6. Colorado, there's 13 or so, I believe. And the links that I have here are to websites that show you where all of those harm reduction organizations are, as well as their contact information. Folks can receive naloxone for free, pretty much no questions asked from these harm reduction organizations. And then there's also these harm reduction organizations, as well as the National Harm Reduction Coalition, have other resources for folks around using safely, around medication-assisted treatment, lots of different resources for folks in addition to just naloxone. Alrighty, there's another myth out there that if folks obtain naloxone from a pharmacy, their life insurance will be negatively impacted. Thankfully, this has not happened in Colorado yet, and the Colorado Division of Insurance has noticed that it's happened in other states in the US, and has stated that they will protect anyone who experiences this unfair treatment. So just so you know, if your patients are asking you about that, you can give them this information. Storing naloxone, fun fact, super safe for kids and pets. Naloxone does have an expiration date. However, we know that naloxone does continue to work past the expiration date. So, expired naloxone is better than no naloxone as a rule of thumb. And if possible, it's important to keep naloxone at room temperature. If it's repeatedly exposed to really extreme warm or cold temperatures, it might slightly decrease in efficacy. However, again, less effective naloxone is still better than no naloxone at all when we're in the situation of responding to an overdose. So yeah, I would encourage you all to encourage folks to keep naloxone where it makes most sense for them. If that means their car, that's okay. It'll still work most likely if they need it. Alrighty, we are very over time. I'm so sorry. You all had some great questions. I do have some resources for you, and I want to have a space for questions as well. Katie, how are we doing? Should we email the resources out?
We're okay to keep talking, actually, because we have someone joining us who's going to talk some more about implementing this in their hospital, but she isn't here yet. She was joining during the last half hour, so we have some time, and her thing won't take the whole 30 minutes.
Okay, cool. I will go ahead and reshare my screen real quick to pull up some resources that I will also email out to you all. Alrighty, can you all see my screen again?
Yep.
Beautiful. So just some resources for you. The National Harm Reduction Coalition has a toolkit for pregnancy and substance use that is wildly informative. There's a lot in here that we didn't even touch on today. So I would encourage you all to check this out for your own knowledge and your conversations with your clients. A lot of it you likely already know too. And then I also have 2 versions of just some guides for using some less stigmatizing language. Yeah, just kind of important for all of us to continue to remember and work on. I like this one because it's really comprehensive, covers a lot of different language that might come up when we're talking with patients. And I have another one too. Cool. You all can still see my screen, yeah?
Yep.
Okay, perfect. This one is from another harm reduction organization in Denver that kind of dives a little bit deeper into a couple specific terms. So this is a resource for you too. And then here is a safety plan. So the safety plan comes from an organization called Safe Project. This is a tool that you all can check out and potentially use with your patients and give to patients kind of as a handout that you go through together. So it has just some different tips for staying safe in substance use, starting with carrying naloxone to check your supply, not using alone, testing for fentanyl, slowing down, and then recognizing an overdose. I really like the bottom part here because folks can fill in what makes sense for them, so they can fill in where they plan to keep their naloxone, who kind of knows where their naloxone is in their house, and other local resources they can access when they need some more support. And then lastly, I also have, this is a 3-pager front and back with some overdose risks and specific methods for prevention. Again, a lot of the things we covered about, trying to avoid polysubstance use, being aware of your tolerance after periods of abstinence. This handout really dives into some of the main reasons why someone may have an increased risk for an overdose, and some specific tips for each of those reasons that they can refer back to if they do use. So yeah, this could also be a tool that you could give folks, especially if your conversation about the topic is kind of limited or limited on time. Talking about substance use is really hard, so having a handout for folks can be really helpful too. All righty. I will stop sharing my screen and do a final call for questions. Oh, Katie, thank you for putting, there's also never use alone business cards that I would really strongly recommend giving out to folks, so that folks know that that hotline exists for them to stay safe. And that's in the chat from Katie. Does anyone else have any other questions for me? And I would just say again, even if our person who is pregnant is not someone who uses substances, but maybe someone really close to them uses substances, uses illicit substances in particular. Getting them trained on naloxone is super huge, and them keeping their family and their friends and their community safe too. Because the person who overdoses can't use naloxone on themselves. It's really, community trainings are the best. And you all are in kind of a unique position to do that because you kind of get to work with people's families. So I would definitely encourage you all to take advantage of that. Thank you so much for having me and being such an attentive audience.
Thank you so much, Marley. For folks on the call, I know this is a lot of information at once, but really our hope is that this will, having gone through this training will help you feel more comfortable talking to your patients about naloxone. And talking to them about using it, for their family members, and making sure they either go home with naloxone in hand, which we'll talk about in a second, or, as Marley said, they don't actually need a prescription to receive the naloxone. It's pretty much at any pharmacy. But I imagine, if you were to hand them something, like I just shared a handout in the chat for a Narcan prescription aid, something that you can hand to patients that they walk home with, that they go home with. So they're reminded that the Narcan is something they need to get if you're not able to give it to them. With that being said, I will now talk about what I've been alluding to about you being able to give it to them. So there's something called the Colorado Naloxone Project, which launched a few months ago. And we actually have 2 of our cohort hospitals that are in the Learning Collaborative have begun, L&D units have begun participating in the Colorado Naloxone Project. It began in emergency departments, and then these 2 L&Ds are joining also. And the point of the Colorado Naloxone Project is that the people who run the project provide technical assistance for teams who are ready to be able to send patients home with naloxone in hand. So prescriptions are great, but we know that 99% of the time, people don't fill those prescriptions. So the best practice is actually to be able to give the patient naloxone in hand, give them education, give them handouts, and send them home with it all ready to go. So that does take a little bit of, the reason that the project is important is because it will help you figure out how to deal with your hospital, like pharmacy and buying and figuring all that out. I don't know all the answers to that, which is why it's another organization that's doing it. But we have Marie Gambato here, who is at Swedish Hospital on the L&D unit and is really leading the charge of having Swedish's L&D unit participate in the Colorado Naloxone Project. So I'm excited for you to hear more about that project from Marie and how it's going for their team, and now that they've been doing it for a couple of months. So Marie, please take it away.
Can you hear me?
Yes.
Oh, good. I'm on my iPad. I wasn't sure because it wasn't working on my phone. Thanks for inviting me to speak about this important initiative that we've done here at Swedish. On August 31st was when we implemented the program for the to provide Narcan to our labor and delivery patients that are at risk for overdose. And that was on Opioid Awareness Day. So that was a great day to launch the program. And we were able to obtain naloxone from a grant that Don Stater, one of our ER physicians, helped facilitate. And so the naloxone is stocked in our Pyxis on the labor and delivery unit. And a provider just needs to put an order in, and then the nurse can pull out the naloxone, and inside there's it comes in a little bag, like a little clear bag. It's 2 doses, and there's a flyer that's inside there, and that the nurse will bring to the patient, scan at the bedside, say not administered, but sent home with patient. And then the flyer has a QR code on it that the patient loads and looks up like you do a menu, and watches a small video, short video about naloxone and the administration, and their family members participate in that. And then there's also a little brochure that just has like 3 steps on how to use naloxone. And we encourage them, like, you know, where are you going to put it, and talk to, you know, your partner, your mom. And since implementing that, we distributed 6 doses last month. And it's been very well received. The nurses are really our front line on this, because they'll say, oh, this patient's a perfect candidate. And then we'll chat with the patient, and they've all been so grateful. You know, they're like, oh, it's free? Oh, we just get it? And I said, yeah, you just take it home and just don't store it in a hot car or cold car. It has to be in room temperature, and it's good for 2 years. And they've been very grateful. So I feel really lucky that, you know, we were able to be a part of this project. And I'm really hoping other hospitals can mimic our model, because it was really easy to do. I put together a lot of the corporate information, and then created one that was just for labor and delivery and postpartum nurses, and put it in a binder for the nurses to read through and then sign that they did. And then they were able to distribute the product. Questions?
I would love to hear, you know, as you've been implementing this, what has been challenging that might be helpful for other teams to be able to anticipate as they might try the same project?
Well, I think one of the biggest challenges is how we're going to sustain this project, because it only works because we can provide it for free right now, and the grant is not forever. And so we're going to need to figure out a way to apply for reimbursement from insurance companies. And there is some movement in that. And we probably have about a year before we are faced with, now what do we do? So I'm hoping something happens before that year is up, so that then we'll be able to replenish our supply or obtain another grant. So that was you know, just a concern of all of ours. And then for the nursing staff, this started out with just the screening tool, utilizing the screening tool from this wonderful group, you know, got us to, you know, really screen our patients. And we hadn't been doing that for substance use. And that opened the door for a conversation for the patients and for the nurse. And that was the groundwork, or the, you know, the lay the foundation for this next step. Without that, we wouldn't have been able to do this, because how would we know that they were at risk? Because just because they possibly have a history, not everybody, it's not in their prenatal record. And a lot of moms they don't have a positive tox screen on admission, because they're really trying to do good with their pregnancy. And they're at higher risk once they deliver to go, oh, I don't have a baby inside anymore. I'm going to go back and see my buddy down the street. And that's where the risk comes in. So that screening tool was key in helping us identify these moms, and then giving the nurses education. So we had to talk about it and make it a common conversation. And that's part of the admission process. Just like the anxiety and the depression is. So it was a process, probably, I don't know, maybe we did it for like 3 months before we launched the Narcan project.
Awesome. We have a couple of questions in the chat. Erica Wymore said, thank you for sharing such great experience. How have your OBs responded to this?
Well, the OBs, it's been a little bit of a challenge with the OBs. They're fine with ordering it, but they're not really on top of identifying those patients. So the nurse needs to be, they're the gatekeeper, so to speak. The nurse calls the OB, says, this patient's at risk. Is it okay if I can put an order in for Narcan? And they say yes. they have not been taking the initiative to do it themselves. I have the unique position that I'm one of the providers there. So when I'm working, or my partner Cindy is, we can order it. And so the nurses will come to us. So the physicians feel that they don't really know that much about it, even though I've sent them multiple emails, put out brochures, talked about it, but they're not that engaged with it. They're not against it, but they're not that engaged with it. But it's new. We've only been doing it for like 6 weeks now.
Another question is, how did you choose which patients to supply with Narcan?
Well, anybody that is at risk for overdose. So if they had a history of opioid use prior to pregnancy or during pregnancy, even if they're in a great treatment program and on, Subutex or methadone, they're at risk. Anybody with a chronic pain that's requiring a lot, like more than 30 milligrams of, oxy, they're at risk, because especially if they've had a C-section, we're sending them home with more oxy maybe, and they're not always forthcoming about how much they take at home. So if they're at risk for overdosing, accidental, I don't think maybe some people are, it's deliberate, but I would say most of these overdoses are just very accidental. They don't mean to do it. And then the moms that they openly talk about how great it's been during their pregnancy, and those are the harder ones. They're like, oh, I'm not going to use. I haven't used in 9 months. I'm not going to use. I have a new baby now. But they're probably at the highest risk, because they get. It's kind of like a liberating, because they're not pregnant anymore. So then they go and use at the same dose that they did prior to, and they don't have their tolerance level. So we just have a conversation about that. And then I also, part of the conversation is maybe some of their friends who maybe they're not using anymore, but they know those people that are. Wouldn't it be something great for you to have just in case? And it's free. And so they're always very receptive. They're not upset that we approach it or offer that to them. They're very grateful. And then somebody that has severe postpartum depression, that maybe had a C-section, that we're sending home on, we really don't like to send people home on oxy, but they've had major surgery. So we send them home on some, but they may be at risk too. So we chat with them about that. So that's the main population.
That's wonderful. Thank you for sharing. And I've put in the chat, I know you shared some resources with us. And I shared a folder with those documents. I don't know if you probably can't see them right now, but if there's anything you wanted to walk through with those, I know you shared the Naloxone take-home kits, huddle notes, anything you want to mention there for those documents?
I think if you just make those available for people they would be able to download them, and then maybe they could look at that QR code and watch the video, because that may be helpful when they're implementing a program at their hospital, because there's no reason to reinvent the wheel. It's all there. And it was a little package deal. So
awesome.
Thanks for taking those documents.
My pleasure.
Yeah.
Awesome. Just curious, for people on the call who work in clinical positions, how are you feeling about, after today's training, your ability or comfort level with discussing naloxone with patients? Or social workers, if if you work clinically, you didn't feel that applied to you. You're part of the team. Anne said much more comfortable. Great. Yeah, and I think like the beauty of this is naloxone is actually, it's very simple. So, you know, you don't need to be able to spout off a training like Marley can spout off, but hopefully this training give you enough information to feel much more comfortable going over like the high level information with patients. And we're going to be sending you tons of resources you can print out and give to patients. You can email to patients. There are so many resources out there, both for patient handouts and education and provider education to make sure, you know, clinical folks are comfortable talking about this. Great, we're getting lots in the chat now. Mandy said more comfortable, still harder to do the conversation than actually administering medications. Yeah, I think we hear that a lot. Marie, have you felt like that has been more of a challenge, is having the conversation than administering the medication?
Well, I think that because we have this, it's free, you know, it's like, it's that it gives you, you walk in and you have a gift to give them, like what I have, you know, and this is what, you know, we just explained that it's a pilot program because of overdoses on the rise. And I know that you're not worried about you, but maybe you are about your loved ones, and can we have the conversation, and you get to take it home, and they don't, I think it's really easy because we're giving them something for free in our situation, you know.
Yeah,
I haven't been uncomfortable having that conversation, and the nurses also. I mean, they've really stepped up with this, and it's exciting. So we can, and the patients see that we're so happy that we have this, and they're like, "Oh yeah, this is great. Oh, can I watch a video?" And oh, is there a way I can email that to my mom? Because, you know, and so it really opens the door. And I don't think you're going to get the same effect if you say, I'm going to write you a script. They're going to be
right.
like, oh, thanks, you know, just what I need. How much is this going to cost me? I mean, I can't even get them to fill a blood pressure script. So,
yeah.
So I think that helps, is that it's free.
Yeah. Well, and so again, for everyone on the call, we are happy to connect you to the people who run this program that can get you the free naloxone. And I know that the people who run that program are definitely, you know, trying to figure out all the different sorts of ways to continue funding it beyond a year. I feel pretty confident that they will be able to do that. And then we also will be happy to, you know, work with our partners at OBH and all of our hospital L&D partners to figure out how we can help sustain this funding. So I guess I just want to say, don't let the fear that this is a temporary grant be your obstacle, because I feel pretty confident that this will be able to be continued funding, funded. But yeah, some more stuff in the chat. Much more comfortable due to the details and accurate information. Very comfortable. Christina said, mom administers the Narcan only when it is a life or death situation. Christina, are you able to say more about that? I'm not quite sure what you wanted to say. Okay, maybe chat in if you can't talk on the phone. Mick Zweig said, I think we need to meet with our pharmacy and see what we have. I'm ready to start having these conversations. Awesome. Again, we're happy to connect you to the people who can help you have these conversations. Marley said most copays are $20 to $30 to get naloxone from a pharmacy. So not nothing, definitely not nothing. Yeah, and Marley, I wonder too, because I know so many harm reduction agencies do have it for free. Of course, they're not in the hospital, but do you have information that we can send out, you know, to include with patient handouts about places that patients could get naloxone for free?
Yeah, absolutely. I was just thinking about that. I have those links to the different places that folks could go. a link to the website that has like the listed all the different harm reduction organizations in Colorado, and then one for all in Montana. But I also might put them onto a handout for you all too, because that can be a little easier than a link.
Yeah, that would be great.
But yeah,
Would love
pretty
that.
much anyone, for all harm reduction organizations that I know of, anyone can walk in and get naloxone, pretty much no questions asked. And it's all free for folks.
Cool. Yeah, it would be great to send that out. Yeah, Christina asked, is Narcan given when the mom is not breathing from overdose? Yes. And correct me if I'm wrong, I think you might be referring to when Marie said the person asked if she could send it to her mom, maybe. And I would say that person maybe meant like, can I send it to my mom so that my mom knows what to do if I overdose? Just reading between the lines here. I don't know if I answered your question.
Yeah, this is Mary. And that's the whole premise or the concept, is that it's a team education. And so their partners, their parents, whoever's going to be around them needs to have the education and watch the video and know where the Narcan is going to be stored, because it's not going to do any good if they can't find it, and know when to use it. And it doesn't necessarily mean that they're not breathing. It just means that their respiratory rate is so slow that they're in danger of stopping breathing. So if they're only breathing 6 times a minute and they're laying there, comatose, it's time to give Narcan. And Narcan is a parachute. It's not going to fix it. It's going to buy some time to call 911. And then if it takes a little while for 911 responders to get there, they can administer it again. That's why we give 2 doses in our kit. And so we tell them that it's safe to give it 2 times. And hopefully they live more than 30 minutes from an ambulance. But so that's the premise for that. Because it's not the patient who can give themselves the Narcan, because it's usually accidental. They didn't even know they did that.
Yep. Yeah, and that's why we've also been talking about, if the patient has loved ones in the room who obviously know that they're using substances and it's safe to discuss it in front of the people in the room, definitely involve them in the education, because the person who has the overdose can't reverse the overdose themselves. Awesome. Well, Mary, thank you so much for being here and talking about your experience. I apologize, I was mispronouncing your name today. So
Everybody
sorry
does.
about that.
Okay. I answered to that. Mary, Mari. It's okay. But it is Mary with an I. So
Okay.
but thanks for inviting me. And you can, share my contact if people have questions when they start putting this together for the individual hospitals, because it would be great if every hospital in Colorado, every labor and delivery unit, it is providing this, for our patients.
Yes. Awesome. Thank you so much. We'll send out all of these things. Before people hop off, Megan, if you could launch the evaluation poll, it would be awesome if we could have you all fill out a very quick evaluation poll on Zoom. And there it is up. And yeah, thank you so much for a great call. We'll stay on the line for a couple of minutes so that you have time to fill out that poll. And any additional questions will be here, so feel free to keep asking questions if you have them.
Katie, I'm going to hop off, but thank you so much again. And I'll email you a bunch of resources. So
Yes, thank you so much, Marley. This was awesome. And we'll take all the resources and I'll send them all out. Like a handout with links would be great, actually, because the way we share a lot of these resources is putting them in like a Google Drive folder. And so
Okay.
if it's in a sheet, people can access the links that way.
Cool. Awesome. Thank you so much.
Great. Thanks, Marley.